Hello everybody. Today we are going to discuss about the ASPEN guideline. Based on expert consensus, we suggest the determination of the nutrition risk, that is nutritional risk screening, that is NRS 2002 and Nutric score be performed on all patients admitted to the ICU for whom volitional intake is anticipated to be insufficient. High nutritional risk identifies those patients most likely to benefit from early enteral nutrition therapy. Objective measurements of baseline nutritional status have been described by ASPEN Guideline and Academy of the Nutrition and the Dietetics. However, nutrition risk is easily defined and more readily determined by evaluation of baseline nutrition status and assessment of the disease severity. All hospitalized patients are required to undergo initial nutrition screen within 48 hours of admission. However, patients at higher nutrition risk in ICU setting require full nutrition assessment. Many screening and assessment tools are used to evaluate nutrition status, such as mini nutritional assessment, malnutrition universal screening tool, short nutritional assessment questionnaire, malnutrition screening tool, and subjective global assessment. However, only NRS 2002 and Nutric score determine both nutrition status and disease severity. Patients at risk are defined by NRS 2002 more than 3 and those at risk with score of more than or equal to 5 or Nutric score more than or equal to 5. Interleukin 6 is rarely available as component of the Nutric score. Therefore, Heland et al. Have shown that Nutric score of more than or equal to 5 still indicates higher nutrition risk. It is suggested that nutrition assessment include an evaluation of comorbid condition, function of gastrointestinal tract, and risk of aspiration. It is not suggested using traditional nutritional indicator and surrogate marker as they are not validated in the critical care. In critical care setting, the traditional serum protein marker like albumin, pre-albumin, transferrin, retinol binding protein are the reflection of acute phase response, that is, increase in the vascular permeability and reprioritization of hepatic protein synthesis, and do not accurately represent nutritional status in ICU setting. Anthropometrics are not reliable in assessment of nutrition status or adequacy of nutrition therapy. Individual level of calcitonin, C-reactive protein, interleukin 1, TNF, and interleukin 6, citrulline are still investigational and should not be used as surrogate marker. Ultrasound is emerging as a tool to expandedly measure muscle mass and determine the changes in the muscle tissue at bedside in the ICU, given its ease of use and availability. A CT computed tomography scan provides a precise quantification of skeletal muscle and adipose tissue depots. However, it is quite costly unless a scan take for the other purposes is used to determine body composition. Both may be valuable future tool to incorporate into nutritional assessment. However, validation and the reliability studies in ICU patients are still pending. Assessment of the muscle function is still in its infancy. How its measurement, reproducibility, and applicability are still being validated for use in critically ill patients and may be of value in the future. We suggest that indirect calorimetry be used to determine energy requirement when available and in the absence of variable that affects the accuracy of the measurement. Based on expert consensus, in the absence of indirect calorimetry, we suggest that published predictive equation or simplistic weight-based equation, that is 25 to 30 kilocal per kg per day, we use to determine energy requirement. Based on expert consensus, we suggest an ongoing evaluation of adequacy of protein provision be performed. In critical care setting, protein appears to be the most important micronutrient for healing wounds, supporting immune function, and maintaining lean body mass. For most critically ill patients, protein requirements are proportionately higher than energy requirement and thus are not easily met by the provision of routine enteral formulation. Patients with the suboptimal enteral nutrition due to frequent interruption may benefit from protein supplementation. The decision to add protein modules should be based on ongoing assessment of adequate protein intake. Weight-based equation 1.2 to 2 gram per kg per day may be used to monitor adequacy of protein provision by comparing the amount of protein delivered with that prescribed, especially when nitrogen balance studies are not available to assess the need. Serum protein markers like albumin, prealbumin, transferrin, CRP are not validated for determining adequacy of protein provision and should not be used in critical care setting in this manner. Now about initiation of enteral nutrition. Enteral nutrition supports the functional integrity of the gut by maintaining tight junction between intraepithelial cell and stimulating blood flow and inducing the release of the trophic endogenous agent. So enteral nutrition maintains the structural integrity by maintaining villus height and supporting the mass of secretory IgA producing immunocyte that compose the gut associated lymphoid tissue and in turn contribute to mucosal associated lymphoid tissue at distant sites such as lungs, liver, and kidney. Adverse changes in the gut permeability from the loss of functional integrity is dynamic phenomenon that is time dependent. The consequences of permeability changes include increased bacterial challenge, risk of systemic infection, greater likelihood of multiple organ dysfunction syndrome. As disease severity worsen, increase in the gut permeability are amplified, and the enteral route of feeding is more likely to favorably impact outcome parameter of infection, organ failure, and hospital length of stay. The specific reason for providing enteral nutrition are to maintain gut integrity, modulate stress and the systemic immune response, and attenuate disease severity. Additional endpoint of enteral therapy may include use of the gut as conduit for delivery of the immune modulating agent and use of enteral formulation as an effective means for the stress ulcer prophylaxis. We suggest use of enteral nutrition over parenteral nutrition in critically ill patients who require nutrition support. In the majority of critically ill patients, it is practical and safe to use enteral nutrition instead of parenteral nutrition. The beneficial effect of enteral nutrition compared to parenteral nutrition are well documented in numerous RCTs involving a variety of patient population in critical illness, including trauma, burns, head injury, major surgery, and acute pancreatitis. While few studies have shown differential effect on mortality, the most consistent outcome effect from enteral nutrition is reduction in the morbidity and ICU stay. Based on expert consequences, we suggest that the majority of MICU and SICU patient population, while GI contractility factor should be evaluated when initiating enteral nutrition. Overt sign of contractility should not be required prior to the initiation of enteral nutrition. The literature supports the concept that bowel sounds and evidence of bowel function are not required for initiation of enteral nutrition. GI dysfunction in the ICU setting occurs in 30% to 70% of patients, depending on the diagnosis, premorbid condition, ventilation mode, medication, and metabolic state. Proposed mechanism of ICU and the postoperative GI dysfunction are related to the mucosal barrier disruption, altered motility, atrophy of mucosa, and reduced mass of gastric associated lymphoid tissue. So bowel sounds are indicative of only of contractility and do not necessarily related to mucosal bag integrity, barrier function, and absorptive capacity. So we recommended that level of infusion be delivered lower in the GI tract in those with critically ill patient at high risk of aspiration or those who have shown intolerance to gastric enteral nutrition. Based on expert consensus, we suggest that in most critically ill patients, it is acceptable to initiate enteral nutrition in the stomach. So, based on expert consensus, we suggest that in the setting of hemodynamic compromise or instability, enteral nutrition should be withheld until the patient is fully resuscitated or stable. Initiation or reinitiation of enteral nutrition may be considered with caution in patient undergoing withdrawal of vasopressor support. At the height of critical illness, enteral nutrition be provided to patients who are prone to GI dysmotility, sepsis, and hypotension, and thus are at increased risk of subclinical ischemia, reperfusion injury involving intestinal microcirculation. Ischemic bowel is the very rare complication associated with enteral nutrition. While enteral nutrition be provided with caution to patients on chronic stable low dose of vasopressor, enteral nutrition should be withheld in patients who are hypotensive, in patients for whom catecholamine agent are being initiated, and or in patients for whom escalating doses are required to maintain hemodynamic stability. For patients on vasopressor therapy receiving enteral nutrition, any signs of intolerance, that is abdominal distension, then increasing NG output or gastric residual volume, decreased passage of stool flatters, hypoactive bowel sound, increasing metabolic acidosis and base deficit should be closely scrutinized as possible early sign of gut ischemia, and enteral nutrition should be withheld until symptoms and intervention stabilize. Dosing of enteral nutrition. Based on expert consensus, we suggest that patients who are at low nutrition risk with the normal baseline nutrition status and low disease severity, who cannot maintain the volitional intake, uh, do not require specialized nutrition therapy over first week of hospitalization in the ICU. Low disease severity means if low disease severity and the normal baseline nutritional status means NRS 2002 less than or equal to 3 and Nutric score less than or equal to 5. Patients readmitted to ICU are a heterogeneous group with a varying degree of nutrition risk and disease severity. Occasionally, patients with low nutritional risk and normal baseline nutritional status and low disease severity are in ICU for more than few days. Provision of aggressive enteral nutrition in the low risk ICU patient population may provide little, if any, benefit early in the first week in the ICU. However, patients deteriorate and their nutritional risk and the disease severity can rapidly change. Low risk patients should be reassessed daily, and if their metabolic rate, disease severity, or expected length of stay worsen, the risk benefit ratio may then favor initiation of enteral nutrition therapy. We recommended that either trophic or full nutrition by enteral nutrition is appropriate for patient with acute respiratory distress syndrome and acute lung injury, and those expected to have duration of mechanical ventilation more than or equal to 72 hours, as these two strategies of feeding have similar patient outcome over first week of hospitalization. Based on expert consensus, we suggest that patients who are at high nutrition risk or severely malnourished should be advanced towards the goal as quickly as tolerated over 24 to 48 hours while monitoring for the refeeding syndrome. Efforts to provide more than 80% of estimated or calculated goal energy and protein within 48 to 72 hours should be made to achieve clinical benefit of enteral nutrition over first week of hospitalization. Trophic feed, usually defined as 10 to 20 ml per hour and 10 to 20 kilocal per hour, may be sufficient to provide mucosal atrophy, maintain gut integrity in low to moderate risk patient, but may be insufficient to achieve usual endpoints desired for enteral nutrition therapy and in high risk patients. Studies suggest that more than 50 to 65% of goal energy may be required to prevent increases in intestinal permeability and systemic infection in burn and bone marrow transplant patients, to promote faster return of cognitive function in head injury patients and to reduce mortality in high risk hospitalized patients. In prospective randomized study, Jean et al. Showed that high-risk surgery patient, that is NRS 2002 more than or equal to 5, who received sufficient preoperative nutritional therapy, that is more than 10 kilocal per kg per day, for 7 days, had significant reduction in nosocomial infection and overall complication compared with patient who received insufficient therapy. No differences were seen between sufficient and insufficient neutral nutrition in low-risk patients. In large observational study, Hale et al. Showed that for high-risk ICU patient with Nutrix score of more than or equal to 6, increasing percentage of the goal energy delivered correlates significantly with reduction in the mortality. The lowest mortality was achieved with enteral nutrition, who provided more than 80% of goal energy. For low-risk patient, no correlation was seen between percentage of goal energy delivered or mortality. We suggest that sufficient protein should be provided, and protein requirements are expected to be in the range of 1.2 to 2 gram per kg of actual body weight per day, or may likely be even higher in burn and multi-trauma patients. Monitoring tolerance and adequacy of enteral nutrition. Based on expert consensus, we suggest that patients should be monitored daily for tolerance of enteral nutrition. We suggest that inappropriate cessation of enteral nutrition should be avoided. We suggest that ordering the feeding status of Neil per mouth for patients surrounding the time of diagnostic test or procedure should be minimized to limit the propagation of ileus and to prevent inadequate nutrient delivery. We suggest gastric residual volume not be used as a part of routine care to monitor ICU patient receiving enteral nutrition. For those ICUs where gastric residual volume are still utilized, holding enteral nutrition for gastric residual volume less than 500 ml in the absence of other signs of or intolerance should be avoided. We recommended that enteral feeding protocol be designed and implemented to increase overall percentage of goal calories provided. Based on expert consensus, we suggest the use of volume-based feeding protocol or top-down multi-strategy protocol be considered. Based on expert consensus, we suggest that patients receiving enteral nutrition should be assessed for risk of aspiration and that steps to reduce the risk of aspiration and aspiration pneumonia should be proactively employed. We recommended diverting level of feeding by post-pyloric enteral access device placement in patients deemed to be at high risk of aspiration. Based on expert consensus, we suggest that high-risk patients or those shown to be intolerant to the bolus gastric enteral nutrition, delivery of enteral nutrition should be switched to the continuous infusion. We suggest that in patients at high risk of aspiration, agent to promote motility such as prokinetic medication be initiated where clinically feasible. Based on expert consensus, we suggest that nursing directives to reduce the risk of aspiration and VAD be employed. In all intubated ICU patients receiving enteral nutrition, the head of bed should be elevated 30 degree to 45 degree and use of chlorhexidine mouthwash twice a day should be considered. Based on expert consensus, we suggest that neither blue food coloring or any coloring agent be used as marker for aspiration of enteral nutrition. They also suggest that glucose oxidase strip should not be used as surrogate markers for aspiration in the critical care setting. Based on expert consensus, we suggest that enteral nutrition not be automatically interrupted for diarrhea, but rather that feeds be continued while evaluating the etiology of diarrhea in ICU patient to determine appropriate treatment. Now about selection of appropriate enteral formulation. Based on expert consensus, we suggest that using standard polymeric formula when initiating enteral nutrition in ICU setting. We suggest avoiding routine use of all specialty formulas in critically ill patient in MICU and disease-specific formula in SICU. We suggest immune modulating enteral formulation, that is arginine or with other agent including EPA and DHA, glutamine nucleic acid, should not be used routinely in MIs. Consideration for this formulation should be reserved for patients with traumatic brain injury and perioperative patient in SS. We cannot make recommendation at this time regarding the routine use of enteral formulation characterized by anti-inflammatory lipid profile and antioxidant in patient with ARDS and severe acute lung injury given conflicting data. We suggest that commercial mixed fiber formula not be used routinely in adult critically ill patient prophylactically to promote bowel regularity or to prevent diarrhea. Based on expert consensus, we suggest considering use of commercial mixed fiber containing formulation if there is evidence of persistent diarrhea. We suggest avoiding both soluble and insoluble fiber in patients at a high risk for bowel ischemia or severe dysmotility. We suggest considering use of small peptide formulation in patients with persistent diarrhea with suspected malabsorption and lack of response to fiber. Then adjunctive therapy. Based on expert consensus, we suggest that fermentable soluble fiber additive be considered for routine use in all hemodynamically stable MICU and SICU patients based on standard enteral formulation. We suggest that 10 to 20 gram of fermentable soluble fiber supplement be given in a divided doses over 24 hours as an adjunctive therapy if there is evidence of diarrhea. We also suggest that while the use of studied probiotic species and strain appear to be safe in general ICU patients, they should be used only for select medical and surgical patient population for which RCTs have documented safely and outcome benefit. We cannot meet recommendation at this time for the routine use of probiotic across the general population of ICU patients. We suggest that combination of antioxidant vitamin and trace mineral in doses reported to be safe in critically ill patients be provided to those patients who require specialized nutritional therapy. We suggest that supplemental enteral glutamine not be added to enteral nutrition regimen routinely in critically ill patients. When to use parenteral nutrition? We suggest that in patients at low nutritional risk, that is NRS less than 3 and Nutrix score less than 5, exclusive parenteral nutrition be withheld over first 7 days following ICU admission if patient cannot maintain volution intake and if early enteral nutrition is not feasible. Based on expert consensus, in the patient determined to be at high nutrition risk or severe malnourished. When enteral nutrition is not feasible, we suggest initiating exclusive parenteral nutrition as soon as possible following ICU admission. We recommended that in patients at either low and high nutritional risk, use of supplemental parenteral nutrition be considered after 7 to 10 days if unable to meet more than 60% of energy and protein requirement by enteral route alone. Initiating supplemental parenteral nutrition prior to this 7 to 10 days period in critically ill patient on same enteral nutrition does not improve outcome and may be detrimental to the patient. So when indicated, maximize efficacy of parenteral nutrition. Based on expert consensus, we suggest the use of protocol and nutritional support team to help incorporate strategy to maximize efficacy and reduce the associated risk of parenteral nutrition. We suggest that hypocaloric parenteral nutrition, that is parenteral dosing, nutrition dosing, that is less than 20 kilocal per kg per day, or 80% of estimated energy need with adequate protein, that is more than or equal to 1.2 gram or 2 gram of protein per kg per day, be considered in appropriate patient requiring parenteral nutrition, initiating over first week of hospitalization in the ICU. We suggest withholding or limiting SO-based IVFE during first week following initiation of parenteral nutrition in critically ill patient to maximum of 100 gram per week if there is concern for essential fatty acid. Alternative intravenous fat, essential fatty acid may provide outcome benefit over soya-based IVFE. However, we cannot make recommendation at this time due to lack of this product in United States. When these alternative IVFE become available in United States based on expert opinion, we suggest that their use be considered in critically ill patient who is appropriate candidate for parenteral nutrition. So, use of standard commercially available parenteral nutrition versus compounded parenteral nutrition administered in ICU patient has no advantage in terms of clinical outcome. We recommended target blood glucose range of 140 or 150 to 180 mg/dl for general ICU population. Ranges for specific patient population may differ, and we are beyond the scope of this guide. Recommended parenteral glutamine supplementation is not used routinely in critical care setting. So, as tolerance to enteral nutrition improve, amount of parenteral nutrition should be reduced and finally discontinued when the patient is receiving more than 60% of targeted energy requirement from enteral nutrition. Now, about pulmonary failure, it suggested that specialty high fat in the low carbohydrate formulation designed to manipulate respiratory quotient and reduce CO2 production is not used in ICU patient with acute respiratory failure. So we suggest the fluid restricted energy dense enteral formulation be considered for a patient with acute respiratory failure. So we suggest that serum phosphate concentration should be monitored closely and phosphate replace without reducing. About renal failure, it is suggested that ICU renal failure be placed on standard enteral formulation and that standard ICU recommendation for protein 1.2 to 2 gram per kg of actual body weight per day and energy is 25 to 30 kilocal per kg per day. Provision should be followed. If significant electrolyte abnormality develops, specialty formulation design for renal failure may be considered. We recommended that patients receiving frequent hemodialysis or CRRT receive increased protein up to maximum of 2.5 gram per kg per day. Protein should not be restricted in patients with renal insufficiency as a mean to avoid or delay initiating dialysis therapy. About hepatic failure, based on it is suggested that dry weight, usual weight be used instead of actual weight in predictive equation to determine energy and protein in patient with cirrhosis and hepatic failure. Due to complication of ascites, intravascular volume depletion, edema, portal hypertension, and hypoalbuminemia. It suggested that nutritional regimen avoid restricting protein in patients with liver failure using the same recommendation as for other critically ill patients. So it is also suggested that enteral nutrition be used preferentially when providing nutrition therapy in ICU patients with acute or chronic liver failure. It is also suggested that standard enteral formulation be used in ICU patients with acute or chronic liver disease. There is no evidence for the further benefit of branch chain fatty acid formulation on coma grade in the ICU patient with encephalopathy who is already receiving first line therapy with luminal acting antibiotic and lactates. About acute pancreatitis, it is suggested that initial nutrition assessment in acute pancreatitis evaluate disease severity to direct nutritional therapy. Since disease severity may change quickly, we suggest frequent assessment of feeding intolerance and the need for specialized nutrition therapy. It suggested not providing specialized nutrition therapy to patients with mild acute pancreatitis, instead advancing to oral diet as tolerant. If an unexpected complication develops or if there is a failure to advance to oral diet within 7 days, then specialized nutritional therapy should be considered. It suggests that patient with moderate to severe acute pancreatitis should have nasooroenteric tube placed and enteral nutrition started at prophic rate and advanced to goal as fluid bolus resuscitation is complete. It is also suggested that standard polymeric formula to initiate enteral nutrition in patient with severe acute pancreatitis. Although promising, the data are currently insufficient to recommended placing patient with severe acute pancreatitis on immune enhancing formulation at this time. So, enteral nutrition be provided to the patient with severe acute pancreatitis by either gastric or jejunal route, as there is no difference in tolerance and clinical outcome between these two levels of infusion. We also suggest it is also suggested that in patients with moderate to severe acute pancreatitis who have intolerance to enteral nutrition, measures should be taken to improve tolerance. It is also suggested that use of probiotic be considered in patients with acute pancreatitis who are receiving early enteral nutrition. And it is also suggested that for patients with severe acute pancreatitis, when enteral nutrition is not feasible, use of parenteral nutrition should be considered after 1 week from the onset of pancreatitis episode. About trauma, similar to other critically ill patients, early enteral feeding with high protein polymeric diet be initiated in immediate post-traumatic period, that is within 24 to 48 hours, once the patient is hemodynamically stable. Immune modulating formulation containing arginine and Fu be considered in patient with severe trauma. About trauma, it is also recommended, similar to other critically ill patients, early enteral feeding should be initiated in immediate post-trauma period, that is within 24 to 48 hours of injury, once the patient is hemodynamically stable. We also suggest the use of either arginine containing immune modulating formulation or EPA or DHA supplement with standard enteral formula in patient with traumatic brain injury. Critically ill patients with traumatic brain injury often have other injuries and organ damage, making them heterogeneous population. The timing of initiating nutritional supplement has important outcome implication for patients with TBI. An early Cochrane review demonstrated a trend towards better outcome in patients who received early nutritional therapy compared those failed late, regardless of route. A prospective study conducted by Brain Trauma Foundation showed the significant relationship between amount of early nutrition therapy provided and risk of death. Optimal energy and protein intake following TBI predicted mortality risk after 2 weeks with 30% to 40% decrease in mortality for every 10 kilocal per kg per day, increase in energy intake achieving a plateau at approximately 25 kilocal per kg per day. Protein requirement may be in the range of 1.5 to 2.5 gram per kg per day. Based on expert consensus, we suggest that early enteral nutrition in patients treated with open abdomen in the absence of bowel injury. Also, it is suggested that providing additional 15 to 30 gram protein per liter of exudate loss for patients with open abdomen. Energy needs should be determined as for the other ICU patients. Open abdomen technique is often used in the management of abdominal content following damage control laparoscopy. When the abdominal cavity cannot be closed primarily without excessive intra-abdominal pressure. This procedure is done primarily following abdominal trauma resuscitation and in cases of post-operative abdominal compartment syndrome. Open abdomen technique is also useful in the management of gross peritonitis, tertiary peritonitis, and infected pancreatic necrosis when abdomen is packed open. Risk factors that lead to consideration of the use of open abdomen technique involve four distinct categories, including reduced abdomen wall compliance, increased intraluminal content, increased content with the abdominal cavity, and high volume resuscitation with capillary leak. Patient may have an open abdomen for days to weeks in circumstances. The ideal outcome is timely, definitive primary facial closure. About burn, enteral nutrition should be provided to the burn patient whose GI tract are functional and for whom volitional intake is inadequate to meet estimated abdominal parenteral nutrition should be reserved for one patient for whom enteral nutrition is not feasible and not tolerated. Providing early parenteral feeding is associated with improved structure and function of GI tract, as evidenced by significantly greater contractility, less ischemia and reperfusion injury, and reduced intestinal permeability in burn patients receiving enteral nutrition compared with those receiving parenteral nutrition. Based on expert consensus, we suggest that indirect calorimetry be used when available to assess energy needs in burn patients with weekly repeated measure. As with other critically ill patients, indirect calorimetry is recommended as most accurate mean to assess energy need. Changes in the burn care, including early exclusion of non-viable tissue and grafting, have reduced the hypermetabolic response in energy expenditure that were reported over 2 decades ago. So we suggested that patients with the burn injury should receive protein in the range of 1.5 to 2 gram per kg per day. We also suggested that very early initiation of enteral nutrition is possible within 4 to 6 hours of injury in patients with burn. About sepsis, it is suggested that critically ill patients receive enteral nutrition therapy within 24 to 48 hours of making diagnosis of severe sepsis and septic shock as soon as resuscitation is complete and patient is hemodynamically stable. In ICU setting, it is widely believed that patients with severe sepsis and septic shock have GI dysfunction at the rate of up to 60%. The combination of compromised GI function and hypermetabolism from exaggerated acute phase response likely lead to the greater risk of malnutrition in this subpopulation of critically ill patients. Nutrition therapy, therefore, would be expected to offer benefit for improved clinical outcome. Initiating enteral nutrition within 24 to 48 hours of resuscitation or when hemodynamic stability is reached is defined as adequate perfusion pressure, stable dose of vasoactive drug, stabilized or decreasing level of lactate and metabolic acidosis, mean artery pressure more than or equal to 60 is associated with improved outcome. We suggest not using exclusive parenteral nutrition or supplemental parenteral nutrition in conjugation with enteral nutrition early in the acute phase of severe sepsis or septic shock, regardless of patient's degree of nutrition risk. We cannot make recommendation regarding selenium, zinc, and antioxidant supplementation in sepsis at this time due to conflicting studies. Plasma concentration of several micronutrients with antioxidant capability is decreased in septic shock patients. Specifically, plasma selenium has been shown to be depressed in sepsis. Selenium is believed to be one of the most potent antioxidant agent in clinical setting. The recommended optimal acute selenium doses for critically ill patients may range between 500 to 750 mics per day. Ideal duration of supplementation being 1 to 3 weeks, depending upon the severity of the disease. The magnitude of inflammatory response following systemic infection is inversely correlated with the plasma zinc level. Such as lower zinc level, the greater the likelihood of organ damage and mortality. It is controversial whether low concentration reflects simply the acute phase response, relative deficiency, and reduced availability and sequestration by the body. While the optimal dose is not known, zinc supplementation in septic patients may have prevent innate immune suppression and risk of secondary infection. Based on expert consensus, we suggest provision of trophic feeding defined as 10 to 20 kilocal per hour or up to 500 kilocal per day for initial phase of sepsis. Advancing is tolerated after 24 to 48 hours or to more than 80% of target energy goal over first week. We suggest delivery of 1.2 to 2 gram protein per kg per day. We suggest immune modulating formula not be used routinely in patients with severe sepsis. Post-operative major surgery. We suggest that determination of nutritional risk can be performed on all post-operative patients in ICU, and that traditional visceral protein level should not be used as marker for nutritional status. While hypoalbuminemia has a value as valid pre-operative prognosticator correlating to increased hospital length of stay, infection, mortality, it has limited usefulness in the post-operative setting. Traditional visceral protein, including albumin, prealbumin, transferrin, are negative acute phase protein and in the post-operative setting reflect dynamic and catabolic response to surgery, stress, injury, infection, or organ failure. They do not reflect the patient's nutritional status. While hypoalbuminemia may have prompted the surgeon to initiate nutritional therapy in the first place, serum albumin concentration would not be expected to change through the course of management until stress metabolism up. Thus, serum protein concentration have no use post-operatively to measure adequacy of nutritional therapy. The NRS 2002 is an important predictor of postoperative complication and is validated for use in surgical patients. Of surgery, as it results in better outcome than use for parenteral nutrition and history. Enteral nutrition is clearly not feasible post-operatively if there is evidence of continued obstruction of GI tract, bowel discontinuity, increased risk of bowel ischemia, and ongoing peritonitis. Enteral nutrition may be feasible post-operatively in presence of high output fistula, severe malnutrition, shock, severe sepsis, and if patient remains stable for at least 24 to 36 hours. In this more complex situation, nutrition management must be individualized to allow for optimal care of the patient. Additional measures that help promote tolerance and increase delivery of enteral nutrition post-operatively include adequate resuscitation, correction of electrolyte, pH, appropriate glucose control, goal-directed conservative fluid management. It suggested that routine use of immune modulating formula in SICU for post-operative patients who require enteral nutrition. Specialized immune myeloid suppression cell following insult, injury, and major surgery rapidly increases level of arginine, resulting in relative arginine depletion. An inadequate supply of arginine adversely affects T cell function and causes subsequent immune suppression. Arginine deficiency may be severe enough to impact production of nitric oxide and negatively affect microcirculation. Formulas containing arginine and omega-3 fatty acids appear to overcome regulatory effect of myeloid suppressor cell. In dynamic fashion, the omega-3 fatty acid, EPA and DHA, omega-6 fatty acid from cell membrane to immune cells, reducing systemic inflammation through production of alternative biologically less active prostaglandin and leukotriene. EPA and DHA have also been shown to downregulate expression of nuclear factor kappa B and intracellular adhesion molecule and E-selectin, which in effect decreases the neutrophil attachment and transepithelial migration to modulate systemic and local inflammation. In addition, EPA and DHA also stabilize myocardium, lower the incidence of cardiac arrhythmia, decrease the incidence of ARDS, and reduce the likelihood of in well-nourished patient undergoing elective surgery, preoperative or perioperative provision of immunonutrition is more important for metabolic condition than for nutritional value of the formula. In patients with poor nutritional status, provision of immune modulating formula perioperatively and postoperatively results in positive outcome benefit. The effect in this later patient may be lost when immunonutrition is provided only pre. We suggest enteral feeding for many patients in difficult postoperative situations such as prolonged ileus, intestinal anastomosis, OA, and need for vasopressor for hemodynamic support. Each case should be individualized based on pursued safety and clinical judgment. Based on expert consensus, we suggest that for patient who has undergone major upper GI surgery, and enteral nutrition is not feasible, parenteral nutrition should be initiated only if duration of therapy is anticipated to be more than or equal to 7 days. Unless the patient is at high nutrition risk, parenteral nutrition should not be started in immediate postoperative period but should be delayed for 5 to 7 days. Also it is suggested that upon advancing diet post-operatively, patient be allowed solid food as tolerated and clear liquid are not required as first meal. Chronically critically ill patient. It is suggested that chronically critically ill patient be managed with aggressive high protein enteral nutrition therapy. Now, obesity. It is suggested that early enteral nutrition start within 24 to 48 hours of admission to ICU for obese patients who cannot sustain volitional intake. Also, it is suggested that nutritional assessment of the obese ICU patient focus on biomarker of metabolic syndrome and evaluation of comorbidity, determination of level of inflammation, and in addition to those parameters described for all ICU patients. So it is suggested that nutritional assessment of the obese ICU patient focus on evidence of central adiposity, metabolic syndrome, sarcopenia, BMI more than 40, SIRS, other comorbidities that correlate with the higher obesity-related risk for cardiovascular disease and mortality. It suggested that high protein, hypocaloric feeding be implemented in case of obesity to preserve lean body mass, mobilize adipose store, and minimize metabolic complication of overfeeding. For all core cases, classes of obesity, the goal of enteral nutrition regimen should not exceed 65 to 70% of target energy requirement as measured by indirect calorimetry. If indirect calorimetry is unavailable, we suggest using weight-based equation and 11 to 14 kilocal of actual body weight per day for patient with BMI in the range of 30 to 50 and 22 to 25 kilocalorie per kg of ideal body weight. Protein should be provided in the range of 2 gram per kg of ideal body weight per day for BMI of 30 to 40 and up to 2.5 gram per kg of ideal body weight for BMI of more than or equal to 40. So if available, an enteric formula with low calorie density and reduced NP should be used. While an exaggerated immune response in obese system implicated potential benefit of immune modulating formula, lack of outcome data precludes the recommendation at this point. We suggest the additional monitoring to assess worsening hyperglycemia, hyperlipidemia, hypercapnia, fluid overload, and hepatic fat accumulation in obese critically ill patients receiving enteral nutrition. Obese ICU patient with history of bariatric surgery receive supplemental thiamine prior to initiating dextrose-containing IVs. Evaluation for the treatment of micronutrient deficiencies such as calcium, thiamine, vitamin B12, fat-soluble vitamin, folate, along with other trace minerals, selenium, zinc, copper should be considered. Now, nutrition therapy in the end of life care. We suggest the ANH is not obligatory in the case of futile care or end of life care. So, ANH should be based on evidence-based practices, clinical experience, judgment, effective communication with family, patient, and authorized surrogate decision makers.